All right. Well, everybody, it looks like we're going back to you driving the conference. So I have some questions on the cards. If you still have any questions that you would like, people will still walk around and grab these. I'll try to group them together as much as possible. And we have Doctors Hackney and I can't say it. Houghton up here to answer the questions. So the first question has to do with, should we avoid artificial sweeteners? And then maybe, what do you think about therapeutic nicotine patches? I thought that might kind of go together. Yeah.
Maybe. Because if you quit smoking, then you end up drinking more Kool-Aid or something.
Yeah, right.
I'll take the first part first, which is, should you avoid artificial sweeteners? There's not terrific evidence in humans that artificial sweeteners are a significant driver of the Parkinson's that we're seeing in the population. I think at a time when people have an option on whether to have sugary, sweet, high-carb foods that might be driving other metabolic problems like diabetes and heart disease, and the Diet Coke is keeping them from drinking a real Coke and worsening their diabetes, the trade-off would be go for artificial sweeteners. Do I think you should probably just drink water instead? Train your body not to need things so sweet? Sure. We know that the healthiest diet that can be utilized for a patient with Parkinson's, and this carries on to other metabolic diseases, is the Mediterranean, or what's sometimes called the MIND diet, M-I-N-D. Mediterranean diet is fresh fruits and vegetables, nut butters, olive oils. Sweet sources of things like agave and honey are probably better than cane syrup or sugar. Avoiding the really high carbs in your diet. The second question about therapeutic nicotine. So that was studied once in a trial that was cleverly called the NIC-PD study, NIC-PD, and it failed. So it did not show a significant change or difference in the long-term treatment or management of someone with Parkinson's disease. There has been a lot of Instagram and TikTok data on the use of these little nicotine pouches, usually by sort of young adults, and the reason that they think that it's making them able to focus more. There may be some truth to that at times. We know that the nicotinic receptors in the brain are acetylcholinergic receptors. Acetylcholine is the powerhouse of memory in our brain. That's what goes down in Alzheimer's disease. But there's not enough evidence to suggest that starting nicotine or using nicotine to prevent Parkinson's complications is a good idea.
Okay, all right. This next question, this will be fun. Are you familiar with Dr. Joel Walsh's claims that he can reverse or cure PT?
No. Because I was going to have to ask you to say the name again. Joel Walsh? There was the guy that wrote the Men Are From Mars and Venus guy. That guy says that he had Parkinson's and cured it, but I don't know.
I've never heard of that.
And
ever.
I might be saying
He should be
it
the
wrong.
keynote next year.
Wallach, so Wallach's?
Wallach's.
Yeah.
Haven't heard of
Mr.
him
I
either.
don't know Mr. Wallach's.
I haven't heard of anybody being cured of PD.
I haven't
You?
either. No, in fact, if I suggest if someone had found it, he wouldn't have just his own blog about it. I think it'd be pretty famous.
It'd be big news. Michael J. Fox would be all over
Michael J.
him.
Fox would be all over it. Correct. Yeah.
This next question, no offense to you two, is for me.
None taken.
Is Tai Chi still used at LSU for Parkinson's disease? It's used for older adults with balance problems. And yes, we still have the program. Contact me after the conference. We even have a sign-up sheet downstairs. Okay?
Tai Chi is, incredible. If you have access to it and can do it, definitely do it. It has some very good gold standard evidence that it's effective.
And we also modify it because I don't know about you, but as we age, we have a lot of joint problems, back problems, and things like that. So there's a couple things we do with it is we try to avoid too much twisting. That goes along with a lot of the Tai Chi regular movements. And we also do it instead of always going toward one side with this movement and another side with that movement, we do it basically bilateral. So if you go this way a couple times, we also go the other way a couple times. So whether you're right side dominant or left side dominant with your Parkinson's disease, that can help. Can you speak about the limitations of DBS for a patient in cognitive decline?
Certainly. So, I gotta. Can you give me? Yeah, it's a kind of a weird one. So DBS has been around since 1987. Professor Benabid in Grenoble, France, was doing them then. 8-hour surgeries, multiple passes. He probably had a couple cigarettes in between each pass, as the French may do. And it came to this country in 1997. And the first thing that we learned in the late 90s, early 2000s, was what a bad candidate for DBS looked like. And that was because with any sort of new opportunity, everyone is clamoring in line to be first. And it turns out pretty reliably, testing, that's better, that patients with progressing cognitive problems, progressing balance problems, and too early in the disease, because there may be some questions about early misdiagnosis. Those were the three groups that we really learned to shy away from. The cognitive piece is because, more than anything else, of the trajectory that the deep brain stimulators themselves take. So recall, this is a pacemaker for the brain. The wire goes in. It goes through a cannula about the size of a McDonald's coffee straw, which is small, but it still goes through good brain to get down to Parkinsonian brain. And that frontal lobe that it goes through is the seat of attention and concentration and planning and executive function and personality and mood. And so we want to see a patient with all sorts of redundancy in their frontal lobe before we even think about making a pass down on a surgery day. It's another reason that we will often stage surgery, so just do one side versus the other, even though the patient may benefit from both sides. And similarly, in our program, and I think in most programs, they do a full neuropsychological battery beforwards so that we can get a good feeling for you on what your cognitive function is. That's 3 hours of your life you'll never get back again, but it's worth it.
What on earth do you mean by redundancy in the frontal lobe?
Oh, good question. So neuroplasticity, much of the things that we talked about on screen that is driven by exercise, allows for greater connections to be made. So all of us have parts of the brain that laid quiet at times and others that are turned on at times. It's not true that what they used to say that you're only using 5% of your brain, or if your wife insists that you only use 1% of your brain, those aren't really true. But we do, in the frontal lobe, recognize that there are connections that are really important, and we can strengthen those connections over time with exercise, with healthy diet, and something I didn't talk about, but is another talk in itself: healthy sleep.
Yeah. I'm going to alter this one a little because our expert in this area has already left for the day. But it says we need information on relationship communication issue challenges in people with Parkinson's with their caregiver, like misunderstanding each other, forgetfulness. But Dr. Hackney, I know you've worked with the cognitive aspects with different people, especially with the tango and the communication you found out there. Can you give us any insight to the evidence you've come up with that may help into maybe addressing the issues that they could with dance therapy, or
Do you mean
the
about
communication
cognitive problems
between
or communication between caregiver and caree?
Yes, or between two people that could occur in dance.
Sure. So often as a dance instructor, you feel like you're a bit of a couples therapist, that's for sure, and I certainly ran into that. Yeah, dancing is a great, partner dancing is a great way to explore different roles that you might have and try to be a little more vulnerable and find ways to communicate. And sometimes having that instructor there or other people there can be real mediators that can lead to better insight and perspective between a couple, for sure. Otherwise, I don't know, at least at Emory, we've got a wonderful social worker, nurse, coordinator, and they address those specific issues because Parkinson's is not only a motor and cognitive situation or condition, but it also affects a lot of mental health issues as well. And so I think a lot of folks should at least go and talk to a therapist and try to work something out and take advantage of any sort of resources so that you can identify issues if you're having some sort of interpersonal issues. Identify them, talk about them with some other experts, and see if you can resolve them for sure. We have those services at Emory. I'm assuming at Ochsner you have something similar, perhaps?
Yes, we partner with the various support groups in the community, but then even homegrown within Ochsner, we've got a full-time social worker in movement disorders that is always available one-on-one. One thing that we did in a group setting, not in Parkinson's, but in a condition called Huntington's disease, that is another one of my passions, is we actually have a support group for care partners and patients, and then we have a care partners only support group. And that, I think, has been very valuable. It's one that we haven't expanded in our Parkinson's disease patient population, but we're still learning about the value of the care partners themselves being together. And you may, the cynic in you might suggest that that's sort of a misery loves company group. It's really not. It's quite the opposite. I think there's a lot of uplift and support that care partners bring to each other. And some of it's quite objective best practices that they can learn from each other too.
I think the American Parkinson Disease Association has been especially good with having support groups all throughout the United States. So be sure to check out the APDA website for the local support groups.
Yes. We do have a Care Partners support group on Thursdays, every what Thursday of the month? Fourth Thursday of the month. And it's in the packet, isn't it? Right, yes. It's in the packet. So we have information on that in there.
And if anybody's interested, you don't have to have a member in our regular support group. We do breakout sessions once a quarter for the patient and care partners, so we have a specific care partner.
So what Randy is saying, I don't know if they can hear you, Randy, so excuse me for talking over you, but correct me if I'm wrong. So in the regular support groups, sometimes they have breakout sessions where they separate the people, the caregivers from the people with Parkinson's at some time during it. So everybody can have their individual conversations and then also come together as a group. Yes? Okay. Yeah, and there's links, they should be provided in your packet, including the Mission for Movement website. Okay, let's go about diagnosis for a second. Should everyone have a DAT scan if they think they have Parkinson's?
No.
Okay, next. No, do you want to elaborate?
I don't know, do you want me to elaborate? Yeah. So I'm of the camp that Parkinson's remains a clinical diagnosis for the vast majority of people. However, the confirmatory biomarker studies, similar to the things that we've talked about, include DAT scan. It's about 85% sensitive, which means about 15% of the time you can get a false negative. And also the SYN1 biopsy. Who's heard of the SYN1 skin biopsy? Smart, yeah, it's a newer opportunity. We've actually at Ochsner over the last, it's probably been about 2 years now, 18 months, we've pivoted away from DAT scans. Not exclusively, I know we have our friend from GE out here, but we're also utilizing SYN1 biopsies a bit more. The sensitivity and specificity is higher. It's also invasive, and so for a patient that doesn't want to have the skin biopsy, it is not a brain biopsy, it's a skin biopsy, 3 spots, ankle, inside the knee and behind the shoulder, little punch biopsy, just get a Band-Aid, not even a stitch. And you get the results back in 2 to 3 weeks, and it is fairly sensitive and specific for Parkinson's disease. But most patients still, in a setting of a neurologist, and particularly a movement disorders, trained and comfortable neurologist can make the diagnosis clinically.
Okay, let's go to medical treatment for a little bit. What do you think about Inbrija, and where does Ritari fit in as a good medication?
So disclaimer, always discuss medications with your treating provider. Inbrija is inhaled carbidopa-levodopa. It's kind of like an inhaler that you would use for asthma, although it's in a powdered formulation. It's a very different looking dongle than what you would use for just your albuterol inhaler. You push it, you inhale it really slowly. If you inhale it really quickly, you will cough. In the clinical studies, something like 70% of patients coughed with the utilization of it. And it's a very effective way to get dopamine into the bloodstream through the alveolar wall. So the lung is a pretty good way to get stuff into your bloodstream fast, like oxygen. And so utilizing Ambrosia for that is effective. I'm gonna botch some of the particular details, but this should be directionally accurate. It works in about 15 minutes, and it wears off in about 45 to an hour. So it is a pure rescue move. If you come to me and you say, I'm glad to be your new patient, will you refill my Ambrosia because I use it every hour? I'll say we need to do something differently. That's not the best way to use Ambrosia. The opposite of Ambrosia, perhaps, is Rytary. So you saw me show Crexont, which was the newest kid on the block. Rytary is the previous extended release drug, which is not quite as extending as Crexont, although the company will tell you they don't have head-to-head studies to demonstrate that. But compared to placebo, the Rytary is not quite as long-acting as Crexont. But I think it has a really important place because it's still significantly more long-acting than the immediate release carbidopa, levodopa, the little yellow tablets that everybody in the room, at least with Parkinson's, has tried at least once. I'm fairly confident. So I think Rytary does have a place. Rytary may have another place in a couple of years when it goes generic, and Crexont will not be generic yet. And so we know that in a free marketplace with generic drugs that's working properly, the generics will go down in cost at that time.
And two more follow-up on that. How does using CPAP machine help Parkinson's patients? And then can someone on high dose of levodopa, carbidopa go on dopaminergic stimulation 25 years after diagnosis?
I'll take the second one first. So I presume you're talking about like the pump, whoever asked that question, high dose carbidopa, levodopa, multiple pills a day. You're actually the perfect patient to think about using Vyalev or Onapgo from my perspective, because you're able to convert all that oral absorptive issues as the disease progresses, where you have slow GI transit, or you're having trouble with proteins, or you're just getting regular old dose failure because your brain's not as efficient as it used to be to store it. Then a continuous dopaminergic strategy of either the oral drugs, the new pumps, or deep brain stimulation is a great idea. The first question is about CPAP. CPAP is for obstructive sleep apnea. It's a lung disease more than a brain disease. It co-marries with patients with Parkinson's, not infrequently, just because the same patients can have both. If you need a CPAP machine for your snoring at night and your obstructive sleep apnea, you should use it. If you don't use it and you have Parkinson's, your Parkinson's can seem worse the next day because your sleep was lousy and your retention of carbon dioxide was too high. If you fix those two things, your Parkinson's gets better. But it doesn't directly treat Parkinson's.
Okay, and I know I'm going to go a smidge over, but I'm going to make it through these last couple to make sure everybody's questions get asked. Will bilateral focus ultrasound be available at the new Ochsner facility?
No.
Okay.
Here's why. Bilateral focus ultrasound isn't available anywhere yet. It was a trick question, whoever asked it. So focus ultrasound is only approved unilaterally right now. It's been done bilaterally off-label. Yes, I agree with that. But unilaterally is the only thing that has the FDA approval. There, in many patients, is a balance in speech problem when you get bilaterally. Yes, when the new machine is open, when the new building is open, though, we will also have focused ultrasound at the same time, following FDA labeling to begin.
Okay, how does PD affect vision? What can be done to treat vision issues in PD? And is it reversible?
So Parkinson's disease does not directly affect visual acuity. Visual acuity is the reason I have these trifocal things on. It does affect eye movements, and it affects eye movements with a very specific feature that many of you have probably struggled with before, which has a fancy name called convergence and divergence insufficiency. What is that? If I'm looking at the exit sign in the back of the room, my eyes are diverging. They're separating apart. If I'm looking at the microphone, my eyes are converging, they're coming together. Parkinson's patients struggle to have the divergence and convergence happen quickly enough and happen in sync. So you may experience eating your dinner, you're looking down at your food and everything's fine, and you look up at your spouse or you look up at the television and they are blurry. And that's because you've gone from converging to diverging, and it takes a minute. But the vast majority of Parkinson's patients, when that happens, if they sit and hyper-focus on wherever they're looking, distant or near, give it a few seconds, it clears up. Because then eyes have been able to catch up with each other, right? So that sort of, it creaks like, comes back together slowly. Once it gets right, though, your vision should be good. If you have another vision problem, one eye isn't working, you're getting shade going down, you're having persistent double vision, you're having persistent difficulties looking down or up, that is not Parkinson's related, but it is neurologic, so make sure you talk to your neurologist or your primary care doctor about that. And the last question was, will it get better? It'll get better if it's the convergence, divergence thing I'm talking about. And the way to get it better is what we used to call pencil push-ups. So imagine you've got a pencil in your long hand and a pencil in your short hand, and you're drawing your eyes back and forth. It'll make you dizzy, but the more you do that, you strengthen the eye muscle. So if you do eye muscle strengthening exercises with convergence and divergence insufficiency, if that's your problem in Parkinson's, it will improve, just like any other exercise improves all your other features of Parkinson's.
And there is some evidence that it does affect something called saccades. They are just an eye movement where you reposition. So everybody, if you look at Dr. Houghton, then look at Dr. Hackney, then look back at Dr. Houghton. Anytime you shift your eyes quickly like that, there's usually a little bit of delay, just like slowing down in the other aspects of Parkinson's disease. So, all right, the last two that I have here.
They're for Dr. Hackney.
What?
They're for Dr. Hackney. The last two questions?
Last two. Is there, you're giving her the toughies.
I'm going to weave you into it somehow, yes.
Is there any value in trying to assist a person with Parkinson's who appears to be not interested and hopeless? And then there's...
You got that, Doc.
Well, let me just take that one.
Thank you.
You mean someone who's experiencing apathy?
Not interested
Demotivated?
and hopeless, like they can't do anything about it, is what I'm assuming.
Sounds like apathy.
The answer is yes.
Absolutely.
One should not give up. One should keep on trying. Find another way. Reach them if they can. If this is a loved one, I presume.
Keep trying.
Oh, go ahead.
I was just going to say, keep trying. I 100% agree.
Yeah, keep trying.
What exactly is mindfulness?
I think Dr. Rao gave a really good talk about it this morning. Does anybody remember what mindfulness was, as per Dr. Rao? Anyone? Oh, go for it. What is it?
I would say, just in a general sense, of being present, being in the moment.
Yeah, being present and being in the moment. I think that's very good. Does anyone want to add to that? That was a long time ago, 9 o'clock this morning.
I took it as like being intentional.
Being intentional, that's good too. Yeah, definitely. I think you can be mindful in just about any situation. And it's about always coming back to your inner introspection. Yeah. Lots of books about it. And she recommended a course, right? An 8-week course. Yeah.
I was before I got to Ochsner, after my training, I had a 5-year stint on the faculty at the University of Louisville, Kentucky, and had the benefits of working with some really interesting researchers in mindfulness. And I was like the regular Parkinson's doc on the study, and these others were really enlightened PhD types. But the study was this, and I'll summarize it in 30 seconds. They took dyads, combinations of a patient and a care partner, and then they had normal control. So they just had a third, probably a medical student off the street. And they did cheek swabs measuring cortisol. Cortisol is a stress chemical. And they measured all the cortisol in everybody. And the control group, the medical student, had the lowest amount of stress. The care partner had more stress than the control. And then the Parkinson's patient had the most stress. And so then they enrolled them all in mindfulness programs, and they all went down. But the group that went down the most was the care partner. So the greatest shift, the greatest benefit to the mindfulness was seen not in the patient. There was still an advantage, but it was seen in the care partner. And so for you care partners in the room, learn to be intentional, if there's such a thing like that, to just tell someone to learn to be intentional. We know it reduces stress, and when you reduce stress, that's healthier for the rest of your body.